request Patil sir to please introduce the speaker.
Namaskar. On behalf of President ISVS Dr. Simran Sagar Singh and myself, Dr. Patil, Executive Secretary, and Team INTAS led by Dr. Nitin Bhatia, I welcome all the attendees of today's webinar. I am very happy and to introduce our speaker of today's webinar, Dr. Kasturi Bhadsavle, a renowned veterinary ophthalmologist. She graduated from Bombay Veterinary College in the year 2004, and later she completed her post-graduation from same institute, and she developed interest in veterinary ophthalmology, and after initial tutelage under human ophthalmologist, she trained further in Israel and United States of America during 2007. In 2009, she moved to Australia and she started practice, general practice, as well as her own ophthalmic consultation practice in Melbourne, Australia. Later on, the love and affection of our motherland attracted her to move back to India in 2017, and her is the first veterinary ophthalmology clinic in India, and the clinic is at Mumbai and Pune, and she started this in year 2019. She is deft in handling all cases, be it cataract, be it corneal grafting, or any ophthalmology related cases. And she loves farm animals, horses. She is versatile, especially in the field of ophthalmology, and her esoteric knowledge will be useful for all the general practitioners, private practitioners, those who are interested in veterinary ophthalmology. I request Dr. Kasturi Bhadsavle for her presentation, please.
Thank you very much, sir, for such a wonderful opportunity and such a wonderful introduction. So I'll start presenting. Okay, is my screen visible?
Yeah.
Yes.
Okay. All right. So my name is Dr. Kasturi Bhadsavle, as Dr. Patil introduced me. This is absolutely wonderful opportunity. Today we are going to talk about corneal grafting. There are a lot of ophthalmic surgeries that we can do. There are ophthalmic, there are multiple ophthalmic conditions which are treated medically. Whereas I mean, not all corneal ulcers need corneal grafting. But today, I hope that I'll be able to, describe which are the cases where you go for corneal grafting, which are the cases the cases which are absolutely gone. I mean, you can't really save lives, and which are the cases which look really ghastly, but you can actually treat them medically. Okay, so this is our little team. I'm very proud of each and every one of them. I mean, the team has grown since then, since this picture has been taken. But we are quite efficient, and we have fun. Before we go, I mean, dive deep into the grafting scenario, I want to just briefly talk about a little bit of anatomy. So cornea is the clear window to the eye. For us to be able to see, or for vision, all these structures between the cornea, between the outside and the retina, need to be absolutely transparent. So all these structures, cornea, aqueous, lens, vitreous, all these structures are avascular. There are no blood vessels in these structures, and the reason there are no blood vessels is blood vessels bring in fluid, and blood vessels blood vessels bring in turbidity. They bring in blood, so they need to be absolutely, for these structures absolutely transparent. There can't be any blood vessels. So, so basically, the cornea is the clear window to the eye. Now, cornea is literally, it is 0.5 millimeters thick. So 0.5 millimeters is not it's not really thick. It's a very tiny little thin structure. There are 5 layers to the cornea. This is the topmost layer, which is epithelium. Now, epithelium is a highly regenerative structure. Okay. Then comes the stroma. Stroma is made up of collagen fibers. Now, these collagen fibers are organized in such a beautiful fashion, in a parallel fashion, that that arrangement of these collagen fibers make the cornea transparent. Beyond stroma is the Descemet's membrane, and below the Descemet's membrane is endothelium. Now, endothelium, you're born with certain number of endothelial cells, and this layer is non-regenerative layer. So, if the endothelial layer is damaged, or if the endothelial cells start dying or degenerating, they do not regenerate again. So basically 5 layers, epithelium, and then the epithelium sits on basement membrane. Then this is stroma, this is Descemet's membrane, and this is the endothelium. Now, cornea, since cornea doesn't have any blood vessels, it has to be nourished. And the nourishment is provided by tear film from outside and the aqueous. Okay, so the tear film is made up of 3 different layers. The topmost layer is lipid layer, which is produced by the meibomian glands in the eyelids. Aqueous layer is generated by the tear glands, and the mucous layer is generated by the conjunctival goblet cells. So the aqueous layer has antimicrobial properties. It has all the nourishment that is required for the cornea to survive. And the same function is done by the aqueous. Now, the aqueous is generated by a ciliary body inside here, and it's a continuous process. So, if there is anything wrong with the tear film, okay, so if there is a dry eye, or if the quality of the tear film is not good, so basically the cornea is left malnourished. And then the body brings in blood vessels to nourish this cornea, and that's when you see keratitis. That's when you see pigmentation. That's when you see blood vessels on the cornea. If there is uveitis, which means if there is inflammation inside the eye, the changes in the the aqueous also leads to the similar effect. In case of chronic uveitis, the cornea starts becoming cloudy. So, about corneal healing. Now, any kind of superficial wounds where the epithelium is scratched, or where there is a superficial corneal ulcer where only the epithelium is involved, and so epithelium being a highly regenerative structure, or highly regenerative layer, new epithelial cells form, and they just slide across. They just slide across the top, and they fill in the defect. Okay, so if, as you can see here, okay, even if there is a stromal ulcer, or even if there is whenever there is a superficial ulcer, the epithelial cells slide across and they heal the cornea. And they actually seal it, and then slowly and steadily the new layers form from below. Now, so superficial ulcers are easiest to heal. Non-healing, uncomplicated corneal ulcers heal within 3 days. It's very, very effective, the corneal epithelial healing. Now, stromal ulcers, on the other hand, heal slowly, And because, so as I showed you before, stroma is contained of perfectly aligned collagen fibers. And if these collagen fibers are, after wound after the wound heals, this parallel formation gets disturbed, and because that parallel formation is disturbed, there's always a scar. Mostly there is a scar in stromal corneal ulcers when they heal. Descemetocele. So descemetocele is when the ulcer is deep enough that it has reached the Descemet's membrane, and Descemet's membrane is few microns thick, and one little bump to the eye and the eye ruptures. So descemetocele or a ruptured corneal ulcers are a surgical emergency. You need to address. You need to push for surgery in these cases. Now, just a quick principles of microsurgery. Everyone here is a surgeon, and we have learned about principles of surgery while we were, going through school. So, microsurgery is not extremely different to a normal, to a routine surgery, but there are some distinct differences. I would insist on gas anesthesia, and especially in small animals when you're performing ophthalmic surgery. Now, don't get me wrong. I'm not like a person who has never ever worked in the field. I've gone to Andaman Islands and I've operated on the beach. So it's been pretty. It's always an interesting experience to work in the field, but whenever you have a chance, you should have. Whenever you are performing these surgeries, these microsurgeries, if you have gas anesthesia, it is most helpful. So whenever I do my horse surgeries or equine surgeries, it's very, very stressful because the horse can move at any moment, and it's just not fun. So comfortable and adjustable seating. Always sit down and do perform microsurgery, because when you are standing up and when you're bending over, your hands are not steady. So you have to always sit down, and your position needs to be absolutely comfortable. Your hands need to be very steady. So I always I have the chairs with armrest. And I turn the chair around, and I basically put my elbows on those armrests. Or if you don't have that, you at least rest your hands on the table, so your hands are absolutely steady. Because if your hands are in the air, or if your elbows are in the air, your hands are going to start shaking after some time. Use magnification. If you have an operating microscope, nothing like it, because it also provides a perfect lighting. If you don't have operating microscope, at least use loops. I have also performed a lot of grafting surgeries without any magnification, but it's again, it's not a nice feeling, and you can make mistakes. Strong focused light in a dimly lit room. So if you have a lot of light around you, it will get reflected of the cornea. So it's better that if you have a strong focused light, nothing matters. But if you don't have a strong focused light, then at least your surroundings will be very bright. Sepsis. Now I use diluted betadine solution to clean the eye. I actually aspirate some of it, in a 5 ml or 2 ml syringe, and I actually go in underneath the eyelid and flush copiously flush the entire cornea, flush underneath the third eyelid, because if that's where all the gunk is. Okay, so you need to flush, and then also you need to clean the eyelids. I don't necessarily clip the hair, because if you can see that the drape that I use has that sticking plastic bit. So I can just cut and only open the eyeball spot. Now, use microsurgery instruments. Sometimes we think that a smaller Mayo scissors will work. It doesn't. So if you are performing, or if you want to start performing ophthalmic surgery, if you want to start performing grafting procedures, then you need to invest in microsurgery instruments. And these instruments needs to be absolutely perfect condition. So I keep changing my instruments. I keep buying new instruments every couple of years or every year. I mean, if there is even a slightest change in that, I mean, if the instrument is not functioning as I want, I discard that instrument. So don't adjust. Always go for the best, because these are your best friends during the surgery. You need to have perfect instruments, and they need to be microsurgery instruments. While you're doing microsurgery, you are not going to use your elbows. You're only going to be using your wrists and your fingers. Okay, so rest your elbows and only use the wrist, because as soon as you start using your elbows, you're going to make big movements. Okay, big movements are not good in a microsurgery. I've seen people suturing cornea with 3-0, 4-0. Not a good idea. Not even horse cornea. Even for a horse cornea, I use 8-0 suture material. So corneal sutures 8-0, 9-0, 10-0 are I mean, those are the good suture materials. Now, corneal suturing, if you I mean, this is a little busy slide, but if you can see here, this is the perfect way to actually enter your needle into the cornea. So you need to go in at 90-degree angle. If you go less than 90-degree, then it's going to be too shallow of a bite. If you go too deep, I mean, if your angle is not right, then you'll go too deep. Okay, and this is the perfect knot. This is the perfect suturing. It needs to be both the sides need to be equidistant. It can go. I mean, do not. So in this picture here, it has actually gone through the cornea. Even if you go through the cornea, it's not a disaster. But what I would suggest is come back out and go back in at a different location and make a knot like this. Okay. Now the way we place the knot is two loops and then one, which is a normal surgeon's knot. Now, now I'm going to talk about the corneal graft. If you have a corneal, this is a human eye, but I mean, this was a great picture of double continuous suture, so that's why I've added it. But basically, whenever you have a graft, you have to put fixing stitches, and then what I do is I go in continuous sutures. So you can put multiple interrupted sutures, but that just takes far too much time. And continuous sutures do equally good job, especially because cornea heals very quickly. Whenever you do a graft, it literally heals within 3 to 4 days. It is completely sealed up by that time. So continuous sutures, if you are confident, I just put one layer continuous sutures. If you want them to be, if you want the wound to be absolutely perfectly sealed, then you can go double layer. Okay, so in this picture here, you can see that there are double layers. So this person has gone one layer and then has also gone in for the second time. Use traumatic instruments. So while you're doing a grafting or while you're handling cornea, if you are using a 2-in-1 forceps or colibri forceps or corneal forceps with 2-in-1 teeth, do not grab that cornea at multiple locations. Okay, you need to find one particular location and then you keep on handling that location, which is basically something that you are going to cut later. Because if you use traumatic instruments on the cornea at multiple locations, I mean, you just have to be aware that you are holding that piece of tissue, and that is not, that is going to, basically you're doing a little bit, I mean, you're causing trauma to the cornea. So you have to handle it very gently. I actually use tying forceps with no teeth whenever possible. Okay. Now get someone to lubricate the cornea at all times. So I have one person dedicated to constantly lubricate the cornea almost every minute, sometimes even more frequently. After I'm finished with the corneal grafting, I usually do a temporary tarsorrhaphy stitch. Basically, take one stitch in the on the eyelids, and what that does is it provides protection to the graft. It also increases the temperature in that area where the lid is slightly, I mean, where the lid is closed. And that increase in temperature, slight increase in temperature helps in healing. So yeah, I like doing temporary tarsorrhaphy stitches, especially after corneal grafting surgery. Now basics are done. I'm going to go into the corneal ulcers now. Now, if you have a patient who's come in with a red eye, suddenly starting to close the eye, and there's watery discharge, you can see that the animal is in pain. Before you start opening the eye and making the animal uncomfortable, more and more uncomfortable, you have to be aware that there is a possibility that there is a very deep ulcer underneath those closed eyelids. Okay, so whenever you have a patient who's shutting that eye down, you have to be careful whenever you are approaching that patient. So I usually put Paracaine eye drops. I know by theory you have to do Shermer tear test, you have to do Menace reflex test, etc. But in cases where the animal is extremely uncomfortable, you have to first make the animal comfortable. Because if you try and force that eye open, I've had this happen where someone was trying to force the eye open and the eye ruptured, like in front of on the table. So that can happen. So be very careful when you're handling patients with who are extremely painful. So do your fluorescein stain and see the extent of the ulcer. Usually these ulcers are associated with edema. There is blepharospasm, which means the animal is holding the eye down, and there is epiphora. And you have to remember that there is only 0.5 millimeters to disaster. So you have to approach these cases very carefully. Now, there are different types of corneal ulcers. Superficial corneal ulcer involves mainly the corneal epithelium. So they're very easy to spot. I mean, it's easy to understand that there is a superficial corneal ulcer, and these corneal ulcers will stain with fluorescein dye. Stromal corneal ulcer is when the ulcer has actually gone deep into the stroma. So this is the stroma, this is the epithelium. Desmatoceles, which means that the ulcer has gone deep and has reached the Descemet's membrane. Okay, so this is extremely, extremely thin. One little bump and this is going to rupture. So this is like a ticking time bomb. Iris prolapse is basically when I'll show you pictures of iris prolapse later, but basically when this is already ruptured, okay, as you can see in this picture, the Descemet's membrane endothelium is all ruptured, and it's a nature's way of saving the eyeball. Basically the iris comes forward and seals this hole. And then this is a melting corneal. Melting corneal ulcer is when the corneal tissue starts melting away. Okay, it can melt away and leave a ruptured eye within hours. So you have to approach them. They are an emergency. Now, corneal ulcers, depending on the depth and chronicity of a problem, can be most easy to treat or can be most frustrating. So if you get a dog like this, okay, there's a corneal ulcer here. If you can see here, if you get a dog like this, I look at this and I was like, okay, this has a potential of becoming a frustrating one. Frustrating because sometimes these corneal ulcers just don't heal. No matter what you do, I mean, no matter how many times you debride them, they just don't want to heal. Whereas when sometimes you see these kind of ulcers, okay, this is a stromal ulcer. So we took him to surgery because if you can see this eye, the animal was in pain. It's not looking that good. But this one it has a potential of either becoming a frustrating one or it has a potential of healing quickly. Just few drops, few antibiotic eye drops, atropine, and it heals. So uncomplicated. So just an example. There was one time I was treating a corneal ulcer for 2 months. I've had dogs come in with the corneal ulcers which have been present for 2 years. So if they don't want to heal, they just don't heal. So uncomplicated superficial corneal ulcer. Now this is what everyone wants. This is what I want. This is my dream ulcer. So heals within 3 days. So what I usually do if I see a corneal ulcer, I just put some local anesthetic drops, which is basically Paracaine eye drops, and use a cotton bud and just do a little bit of debridement, just as my first consult. I use broad spectrum antibiotic eye drops like moxifloxacin. And then you have to understand that corneal ulcer is not just the ulcer. I mean, it's not just on the surface of the eye. Basically, corneal ulcer causes a lot of pain and inflammation. It attracts a lot of inflammation. So you have to treat the uveitis that is basically created by the ulcer. So you have to treat, uveitis is internal inflammation of the eye. So you have to treat it by atropine eye drops, systemic pain relief. Do not use FLUR. I mean, you cannot put topical pain relief eye drops. These do not work. They only cause damage. So whenever you have a corneal ulcer case, you have to treat it systemically. So treat the pain systemically. Do not treat the pain topically. I've had far too many ruptured corneal ulcers because some vets have been using Ciplox D eye drops. People use ketorolac, Ophthocare KT, or the PD eye drops. Prednisolone eye drops. These are disasters waiting to happen. Do not use any topical pain relief or any topical anti-inflammatory eye drops whenever you have an ulcer. You have to treat it systemically. I use doxycycline because doxycycline gets released by the tears. It also has anti-inflammatory properties. It helps in healing. So I love using doxycycline whenever there is a corneal injury. Now, indolent corneal ulcers, these are the most frustrating ulcers because they look superficial, they're not dangerous, but they are painful, and no matter how many times you debride them, they just don't go away. So there is always, these indolent corneal ulcers have loose epithelium. So if you use cotton bud, you can actually see that the corneal epithelium is peeling off. So I do algal brush debridement. So algal brush, I have a video for you about algal brush, but I use algal brush because it's not as traumatic. This is grid keratotomy. It is done with a needle. Now this can be a little devastating if you go too deep and go and you're not. If a person is not that used to it, then this can be a disaster while performing a grid keratotomy. Whereas this is fairly safe. Any untrained person, it doesn't need a lot of training. So And it's not very expensive. It's about 10,000 rupees for the algal brush. Do not use any fluor or corticosteroids on any kind of corneal ulcer. So this is the frustrating case. As you can see that the ulcer is about this big, and after debridement, it has gotten about this big. Now, in my on my finger, this is a bandage contact lens. So I use bandage contact lenses on these debrided cases because it acts like a band-aid. It provides pain. I mean, it provides protection from the environment because when you debride, there are open nerve endings, and it's very, very painful. So when you put this bandage contact lens, it's very animals become suddenly comfortable. So these are I couldn't find a picture of a bandage contact lens, but you basically get AccuView bandage contact lenses. These are made for humans, so they don't really fit perfectly on some corneas, and they're not as big as our patients' corneas. Because this is an Anvision's contact lens, and it is made. I mean, they actually make it for dogs and different types of dogs. They also make it for different types of cats, horses. It's pretty amazing. And they also have these little black dots so that the owners can tell whether the bandage contact lens is in the eye or not. So I love Anvision lenses, but due to COVID, we just can't get them in. So so we use AccuView lenses. And this is a little video of algal brush debridement. So you can go quite fairly. You can be fairly brave, and it doesn't rupture or it doesn't cause any damage. It only debrides the epithelium. Now, temporary tarsorrhaphy is something that I perform after a grafting procedure, but if you don't have the facility to perform grafting, you can debride the ulcer a little bit and then perform. I mean, it's better than doing nothing. I don't like doing it because then in that case I can't really see what's happening, whether the ulcer is going deeper or whether the ulcer is getting whether the ulcer is getting infected or whether it's healed. So I don't really completely close the eyelids. I do keep a window where I can see something. I personally never do this for corneal ulcers. I do this only when they are performed the graft. Now, third eyelid flap, I do not do third eyelid flaps for any kind of ulcers. But if you don't have the resources or if you don't have the skills, this is better than doing nothing. Again, I don't like doing this because you can't really see what is happening behind this, whether the ulcer has gone deeper or not. Amnion graft. So if I have a superficial corneal ulcer, which is a non-healing corneal ulcer, and in that case, I basically provide. So I do 3 algal brush debridements. Three as in if I do first algal brush debridement, I always warn the owners that there is a possibility that the ulcer may not heal with one. If it heals with one, basically it's it's a joy. Then we repeat it the second time, and then we repeat it the third time. And if after third time the ulcer hasn't healed, then I give the owners 2 options. Okay, one option is keratectomy. Keratectomy is basically removing the top layer of the cornea, and it heals. It basically the success rate for keratectomy is almost 99%. I've never seen it fail. But the downside of keratectomy is that it causes a lot of scarring. I mean, sometimes some corneas, especially pug corneas, they become white, or black. So Then I found amnion graft, and it's I love amnion graft because it causes very less scarring. So it is stored in the freezer. It is harvested from a human amniotic sac, and it's treated for multiple months and years. It is rich in stem cells, and that's why it helps in healing. It provides bandaging effect, and basically the graft gets degenerated within few days after performing this procedure, and there is very minimal scarring after the surgery. So this is amnion graft. So this is how I'm basically fixing the eyeball. So whenever you are performing any kind of ophthalmic surgery, your position needs to be perfect and your eyeball needs to be nicely fixed, or in a good position. So this is a superficial ulcer. I mean this is an eye where we've done algal brush for 3 times and it still hasn't healed. So before we perform the amnion graft, there is a little bit of algal brushing that was done. And this is an amnion graft. So this is a wet amnion graft. There is a dry amnion graft available as well, but wet gives the best results. And it's not that difficult to handle either. It's very fragile though. So you spread the graft and then cut off the excess. Then after cutting off the excess, I usually place 4 fixing stitches and then go continuous layer. So this is extremely fast forward, but it takes a long time to go around the globe. Okay. Now, stromal corneal ulcers. So stromal corneal ulcers can also be treated medically, and they're not necessarily surgical cases. So and the medical treatment is the same as a superficial corneal ulcer, where you treat the uveitis, you treat it with topical antibiotic, treat it with doxycycline and systemic painkillers. Okay, do not use any topical anti-inflammatory agents like any kind of NSAIDs or steroids. They make the ulcer go deeper. They make the ulcer not heal. So do not use any of the NSAIDs or topical steroids for these cases. You need to recheck. I recheck the next day, and if the ulcer looks the same, and if the animal is in equal amount of pain and discomfort, then I take it to surgery. Because these ulcers have a potential to become they have a potential to become desmatoceles very quickly. Now, when I recheck the next day, the ulcer looks the same, but the animal has become suddenly very comfortable, then I let it go. I keep checking it. I keep asking the owners. I ask the owners to keep sending me pictures every day. And after 1 week of starting the treatment, if the animal has become fairly comfortable, but the ulcer looks the same, then I take it to surgery. Now, corneal glue is a good option in my opinion, especially in cases where the animal is not a perfect anesthetic candidate, or if the owners don't want to spend the money, or if it's a very small ulcer and you can actually glue it in, it's a much quicker procedure. So this is an example of a corneal glue. So usually, if it's a huge corneal ulcer, then I do not use corneal glue. Also corneal glue causes a lot of scarring. So the owners need to be aware of that as well. Descemetocele with a very tiny, sometimes the descemetocele is only, few millimeters wide, 1 millimeter pinpoint descemetocele with a wide, base, not the base, the top part. In that case, you can use corneal glue. I've used corneal glue in those cases, and they've done, pretty well. But if it's a huge descemetocele with a big base, of a descemet membrane, then I do not use corneal glue. Corneal glue does not stick to the descemet membrane, and sometimes if the entire thing falls off, this actually corneal glue becomes like a it becomes like a cement. It becomes very hard, and if that hard thing, entire thing just falls off, then it will leave a ruptured corneal ulcer. So all these things you need to be, the owners need to be aware, and you'll be surprised a lot of owners go for this because this is a lot cheaper. Do not use it in a ruptured corneal ulcer. If there is a leak, corneal glue will not stick to it. Whenever you are putting the glue, the surface of the cornea needs to be absolutely transparent, absolutely dry. And the success rate, in my experience, is pretty good. It's about 90%. Deep or ruptured corneal ulcers. Okay, so now this is a descemetocele. It's absolute surgical emergency because look at the eye when it's such an angry eye. This is a ruptured corneal ulcer. This hasn't ruptured yet. So if you graft this, the success rate would be very, very good, very high. Now this is a ruptured corneal ulcer where there is an iris prolapse. This blob here, the darkish blob here, is basically the iris which is sealing the hole. Now this dog still has a very good chance of retaining vision after the grafting. The only reason I say this, just by looking at this picture, is because I can see a pupil here. Okay, the rest of the pupil is still there. And you can, whenever you can see this, whenever there is a rest of the pupil that is visible, if you graft this, if you cut this, piece of poking iris out and you do a grafting procedure here, most likely this dog is going to regain vision. This is a descemetocele, pretty huge, large base. I would not do this ever, whereas this needs grafting. When do you push for surgery? Non-healing corneal ulcer, whether it's a superficial ulcer, whether it's a stromal ulcer, or whether it's a descemetocele. If it's a non-healing ulcer, you have to push for. Surgery is the best option in those cases. Fast progressing ulcers with significantly distressed patients. So if the patient remains painful, if the patient remains, squinty and lots of discharge, I would take it to surgery. If there is a descemetocele, I would push for surgery today or tomorrow. It cannot be more than that, because then there is a definite chance of the ulcer getting ruptured. And if the owners want to push it, it's on them. But you need to push for it. If a grafting procedure is performed before the rupture, vision can be saved in almost all of the patients. But after the rupture, the success rate goes down. Okay. The success rate goes down to 50% because there is no guarantee that after the grafting there will be vision. Because whenever just imagine eyeball as a fluidy structure, as a fluid-filled balloon where you're rupturing that balloon. When you rupture the balloon, the entire thing just gets, it collapses, and that collapsing action can actually lead to retinal detachment, or there could be bleeding behind the retina. So after the ulcer is ruptured, the success rate of surgery goes down. Ruptured corneal ulcers can still be saved. Not all. I'll show you examples. If you operate them early on, if only part of the iris is prolapsed, as I was telling you about before, and you can see the rest of the pupil, consensual PLR is present. Okay, when you shine the light in the ruptured eye, and if the pupil on the other side constricts, that means the retina and the optic nerve is still probably intact. Dazzle and menace reflex are present. That's great. That's 1+. And if the above conditions are not met, Okay, I'll show you an example later on as well. If you don't see a consensual PLR, if there is no dazzle or menace, then you can actually tell the owners that operating this eye basically means that we are trying to save the globe. There is no guarantee that there's the chances of regaining of vision in this eye are next to nothing. My go-to procedures for deep or ruptured corneal ulcers, my favorite is the corneo-conjunctival transposition graft, or CCT. Um, I'll tell you later why. Then there is Vetrix biosis graft. These are discs that are made from swine submucosa, intestinal submucosa. This is a dry graft. And conjunctival flap. I know conjunctival flaps are easy to do, and they are better than having nothing. I mean, having to do no graft. But if you have a ruptured corneal ulcer, or if you have a huge descemetocele, I mean, I don't perform them anymore, but they do not provide tectonic support. Tectonic support means that whenever you have lost so much of thickness, conjunctival graft offers only a very thin support. Okay, you need a tectonic support, which means you need to have a thicker grafting material whenever there is a deep or ruptured corneal ulcer, which conjunctival flap doesn't offer. A corneo-conjunctival transposition graft, and this is a huge descemetocele. This is the final graft, the way it looks. So basically what I've done is I've taken, so you go half thickness of the cornea, okay, and you use this portion of the cornea which is good and healthy, which is not ulcerated. You discard the half thickness of this portion of the cornea, and you separate this portion of the good portion and you slide it across. And when you slide it across, you have to also slide it with the conjunctiva. And this is 1 week after the surgery of this patient. This graft became even more thinner and more beautiful. So the good thing about this graft is the corneal portion becomes transparent later on. Okay, so whenever there is a corneal ulcer right in the visual field, if you have a transparent cornea instead of a scar caused by the conjunctival graft, it's always a better option. This is a short video of a conjunctival, CCT. So this is a ruptured corneal ulcer, and what I'm doing, I mean, this is an extremely fast forwarded video. It takes at least 45 minutes to do this. But if you can see that this is a very soft eyeball because it's a ruptured corneal ulcer. You can see in the center there is an iris prolapse. So what I'm doing right now is I'm separating just the half thickness. I'm separating the cornea, the healthy cornea next to the rupture or next to the ulcer. And that's going to be my graft. If you notice that I am handling, this is a 2-in-1 forceps. I'm handling the tissue which I'm going to remove later on. I try and avoid using. I try and avoid handling the actual graft, the actual good portion of the cornea that I'm going to graft. So this is again half thickness. So whenever if you have to handle the grafted tissue, it's fine. But you have to be aware, always, you have to be aware that you are handling, you're causing trauma to the graft. So I've basically separated the corneal portion. Now I'm separating the conjunctival portion. This is limbus. And this graft should easily sit on the should easily sit on the grafting bed. So all these, the way I'm handling this, even though it appears it's very, brutal, but it's not. It's very, very gentle. This is a viscoelastic material that I'm injecting to push the iris back. And that iris prolapse was not huge. I mean, it had not really come out. So I could just push that back in. If it was basically an iris prolapse which has been sitting there for the last few days, then I cut that iris off. The iris which is basically prolapsed out. Okay, so these are my fixing sutures. So I fix the graft with these 2 interrupted stitches, and now I'm basically going to go in and with just one single continuous there. So if you notice that I'm handling the cornea as less as possible. So so the graft is stitched up. Okay. And this is Rufus, who's a 6-year-old Labrador. There's a huge descemetocele. We did this in the lockdown. This dog developed this descemetocele. The referring vet was treating it for a few days or a few weeks, but then it wouldn't heal, and then it reached the descemetocele stage. We did a graft, similar looking graft. The same graft that I did for the other dog, and this is how the graft looks, completely vascularized on day 7. And then we start them on tacrolimus ointment, which thins down the graft and which gets rid of the blood vessels. And this is after about 3 months of the grafting, so it's barely visible. Now, this is Muffy. He's a 5-year-old male pug. They lived in, this is actually a rescued pug, and they lived in Aurangabad, which is about 5 hours drive from Pune. And they sent me this picture, and I looked at it and I was like, what? And they were asking, "We'll come over if you can save the vision." I was like, I cannot guarantee that I can save the vision when the eye is ruptured. But you come over. The only reason I told them to come over, and usually if I see a disaster, then I basically tell them, don't come over all the way. Get the eye removed where you are. So I looked at this, and this eye has ruptured from the side. It's not in the center. It is on the kind of like on the periphery. And I looked at this picture and I could see a little bit of pupil. Okay. When the dog came in, while the dog was traveling, I told them to start the dog on atropine eye drops. And by the time the dog reached us, I could actually see his pupil, and he was visual in this eye with this disastrous looking pupil being outside. So I basically cut this pupil off. I cut this iris off. I pushed the remaining iris inside with the viscoelastic and then did a sliding corneal graft, and he's visual, he's doing beautifully. So this dog came to us yesterday, literally yesterday, and I removed this eye today. The reason I removed this eye and did not even try or did not even attempt, and this is only 11-month-old pug, male pug. But as you can see, that it's right in the center. It's absolutely in the center. There was no dazzle reflex. There is no menace reflex. There's no consensual PLR. Okay. Yesterday, the pressure in this eye. Yesterday was day 1 of a rupture. Yesterday, the pressure in this eye was 6. Whereas today, before removing the eyeball, I checked the pressure and it was 55. So even if I had operated this dog yesterday, there was no chance of saving vision, first of all, and it would have definitely led to glaucoma. So usually in my experience, central ruptures are bad. Vetrix biosis graft. It is made from porcine small intestinal submucosa. These come in dry discs. It can come in also in a dry sheet. I love these because they're very easy to handle, and you can take them anywhere whenever you are in a hurry, or if it's a horse who is ready to wake up, maintained on injectable anesthesia. I use these grafts. If there is a deep corneal ulcer or if it's a ruptured corneal ulcer, you can even stack them on each other. You can make them double or triple and stitch them to the cornea. This is a desmetocele, and this is after the graft. They do pretty well. I've had 1 or 2 cases where the graft actually melted away far too early, and that led to we had to repeat the graft. So in the second time I did a sliding corneal graft, and that's why sliding corneal grafts are my most favorite, because they don't really do this. They don't melt away. So usually the graft degenerates within 2 to 3 weeks. Conjunctival flaps or conjunctival grafts, I do not do them for deep or or any kind of corneal ulcers anymore. But I would do them. I would do these grafts if there is a corneal abscess, because whenever there is a corneal abscess, you have to go deep down, and you have to use you have to perform a keratectomy. You have to go deeper. You have to remove that abscess, and then you need to put blood vessels on it. Okay, and the best way to put blood vessels on is take the conjunctival flap and put it on. If there is a melting corneal ulcer, I'll talk about melting corneal ulcer on my next slide. But if there is a melting corneal ulcer which is not responsive to the medication, there is no cornea left to perform sliding corneal graft or perform the transposition graft. So in these cases also I would use a conjunctival flap. It is not a tectonic graft. Now, melting corneal ulcers, these could be this could be infected, or these could be sterile corneal ulcers. We wouldn't know until we do a cytology, so I always take a cytology sample and send it off. Perform a cytology and send it off to the lab, or I check it myself. Most of the times, if it's infected, it is Pseudomonas, which is which has the tendency to melt things. The antibiotic of choice for me is tobramycin, because it kind of controls Pseudomonas infection. So whenever I see a melting corneal ulcer, I start putting the drops in literally every 5 minutes for first half an hour, and then so every minute for the first 5 minutes, and then every 5 minutes for the first half an hour, and then every hour. Basically, you have to concentrate that antibiotic into that, just increase the concentration of antibiotic, of tobramycin. Then I do not use serum for any other corneal ulcers. I use serum for these ulcers because for a specific reason. Serum has anticollagenases. So whenever you have a melting corneal ulcer, it's basically the collagen is melting away. Okay, there are collagenases. The enzyme collagenase is working on this collagen, which is melting it away. So when you need something which will counteract or which will stop the collagenases. So serum has anticollagenases, and that's why I use serum in melting corneal ulcers, whereas the other corneal ulcers don't really need serum. Topical antifungals only if they're indicated. Topical atropine is extremely essential. These corneal ulcers, definitely there is uveitis, so you need to use atropine. You need to use oral doxycycline, oral pain relief. Do not put any topical pain relief, topical anti-inflammatories. I'm telling this again and again because I see so many of these cases, and end up in disaster because of using ketorolac eye drops or using steroid eye drops, or FLIR is people's favorite. Surgical grafting if it's not responding to therapy. So in this case, I would use conjunctival flap. Full thickness corneal grafts. Full thickness corneal grafts are in humans it's for clarity. If you use a fresh cornea, you actually get a transparent corneal cornea after using the full thickness corneal grafts. But in our patients, unfortunately, they get a lot of reaction. In cats, people have been successful with keeping the cornea transparent because cats don't get as much inflammation compared to dogs or horses. So in dogs, whenever you use a full thickness corneal graft from some other animal, then you basically are saving the globe and not vision. Or you're trying to use, because this is a huge rupture. You're putting a graft on. It is a tectonic graft. That's it. It's a tectonic support, and then it heals with a lot of scarring. And just as a last thing, we can only use, out of the eye, we can only use cornea or sclera as a grafting material. So if you're removing an eyeball from some other animal and you're using, you're transplanting something, you can only transplant cornea or you can only transplant sclera. Nothing else. You cannot use anything else from other animal in the eye. Okay, we cannot transplant the entire eyeball. I've seen newspaper, articles where people are claiming that they actually transplanted the entire eyeball, and people are going gaga about it. It's impossible. You cannot transplant a nerve. So it is a neurological structure, eyeball. So you cannot transplant entire eyeballs. That's an absolute myth. At least now, in this day and age. So that's my dog, Ella. Thank you very much. If you have any questions, please let me know.
Divyesh, please ask question.
Thank you, Dr. Kasturi. We have a few questions. I'll bring them to you one by one. First question is, which suture material do you prefer for corneal suturings?
So I use 10-0 Vicryl, but you can also use 10-0 nylon. But if it's a with Vicryl or with dissolving stitches, there is always a bit of reaction. Whereas with non-absorbable suture material, there is very less reaction. But you have to go back in and remove those stitches. So my preferred one is Vicryl, 10-0 Vicryl.
Thank you. The next question is, can we push the prolapsed iris inside instead of cutting it out? What happens if the pupil structure, if we cut out the prolapsed iris?
So if it's a if it's a I mean the tissue, if the iris has been out for a while, then it's basically a necrotic tissue, and you cannot push the necrotic tissue back in. So you have to cut it. I mean, you have to remove it, because if you push that tissue back in, then it's going to start degenerating inside the eye, which is going to attract a lot of inflammation. So instead of all that, you just basically cut the necrotic tissue out, or a tissue which doesn't have as good a blood supply, because then anyway. So when you cut that iris off, it doesn't really affect the vision as significantly.
Okay, the next question is where do you procure the amniotic membrane from and how long can you preserve for use?
So I get it from my supplier, and it's readily available for human use. So if you have a human ophthalmologist nearby, just ask them for their supplier, and you'll be able to procure one. And I keep mine in the freezer, not in the. It doesn't need to be in the cryo thing and stuff. I mean, it doesn't need to go in the liquid nitrogen. But I put mine in the freezer, and it lasts for about 6 months. I guess it must be lasting longer, but I mean, I would keep it maximum for 6 months.
Thank you. One question is coming up frequently, though I have tried to answer the query, but I'll like to bring it forward to you also. Which type of solution you prefer for lubrication of the cornea during the surgery? Any specific concentration?
You can use you can use RL to lubricate the cornea. RL is good enough.
Yeah. One question is coming up for the future, for a future perspective. Somebody is looking forward for specialization in ophthalmology. So the question is, which college offers good learning in ophthalmology for postgraduate levels?
There are a lot of colleges, but you should. I think you will be able to answer that question better, doctor.
Yeah, sure. I'll reply to the applicant on the chat itself. And the same applicant, same participant has one more question is, what are your perspective of growth in veterinary ophthalmology for the coming years?
What is my perspective, or what I am planning to do?
Your perspective of growth of veterinary ophthalmology in coming years.
It's specialization in India is just just definitely just starting, and it's going to go boom, because everyone. I mean, the new generation vets. They I can see this happening in Mumbai and Pune. Quite evidently, that the newer generation vets, they want to specialize, and everyone has their own little special interest. So some have special interest in what do you say, exotics, especially I mean, surgery students. They kind of know that they like eyes. So yeah, and there are a lot more opportunities available as well. So I think the specialization field in general, I mean the ophthalmology specifically, is going to grow, because it's absolutely a need of the hour. We are constantly filled with cases. We do a lot of I mean, there's a lot of debate about teleconsult, but we do teleconsult, and we try and solve queries, we try and refer cases, but there are very few places you can refer. If the people are if the patient is in some other state, so there is a huge opportunity here to specialize and to become ophthalmologist. And there is a because we are at zero. There's always the only way that we can go is up. So there's always a growth, opportunities there.
One question is, what concentration of betadine do you use for flushing of the eyeball and the eyelids?
So I going to come, but basically I tell my techs to make it like diluted urine color. So because in private practice we can't really just say okay, I need this concentration. So I think it's 1:60, but yeah, I just make it diluted urine color.
What is the difference between human and dog's iris?
Dog's iris is very vascular. So if you cut it, it's just going to bleed like crazy. Whereas in human iris, it doesn't bleed as much.
How frequently do you perform ulcer brush debridement?
So whenever I see a non-healing corneal ulcer, superficial non-healing corneal ulcer, I perform algal brush. So I do at least between two clinics about 6 to 7 algal brushes a week.
Thank you very much. I think that's all for the question and answer session. I'll proceed towards the closing of the session. First of all, I would like to thank our today's speaker, Dr. Kasturi, for her excellent presentation and enlightening everyone with corneal grafting in veterinary practice. So, as we all know that corneal perforation is frequent clinical presentation in human and veterinary ophthalmology, and full thickness corneal defects represent an ophthalmological emergency threatening both vision and preservation of patient's globe. In veterinary medicine, other surgical techniques apart from keratopathies have been reported for successful management of corneal perforations, such as several grafts which were elaborated by Dr. Kasturi, which have evolved dramatically over following decades. At present, I believe that the best hope for curing corneal blindness is corneal transplantation, which is also known as corneal grafting. And I just went through a literature and I saw that according to WHO, more than 1,20,000 corneal transplants are performed each year worldwide. And cornea are one of the most common solid tissues that are transplanted. Corneal grafting for the treatment of full thickness corneal defect in veterinary patients is very effective in preserving vision. So our today's webinar will serve useful by providing guidance to all eye care workers and pet animal veterinarians who want to know who should be referred for a graft and what complications they may need to manage their patients have had their grafting done. Thank you, Dr. Kasturi, for such a wonderful presentation. I would also like to thank the President and the Executive Secretary of the Society, Dr. Simrat Sagar Singh sir and Dr. Deepak Patil sir for their guidance and support. Further, I would also like to thank the organizing team and knowledge partner INTAS Animal Health for their constant support. Thank you, Dr. Deepak Tiwari, Dr. Neelesh Sindhu, Dr. Nitin Bhatia, and Dr. Amanjot. Thank you, everyone, for being with us. Thanks a lot. Thank you.